Good morning, everyone. My name is Noor, and as mentioned, I am a third-year respiratory therapy student from Fairmont College in London, Ontario. And firstly, I really want to show my heartfelt gratitude for you all joining me here today. And I would also like to thank CSRT for giving me this wonderful opportunity. Now, before we begin, I know that it's early, so I really do hope that everyone has had that opportunity to fuel in on their morning coffee. Today, I'm about to talk about a topic that is one that's very fascinating, but it's also one that's very special to me, and it sits in one of the most demanding spaces in critical care. Oftentimes, it's a clinical scenario that can be overlooked, but it definitely does carry serious implications for our practice today. Now, before I begin this presentation, I just want to start off with giving you all a quote. Sometimes the greatest danger in critical care is not what we fail to treat, but it's what we fail to recognize. And what that looks like in practice is what I want to walk you all today. Now, I want to take you all for a few minutes into a patient scenario. Now imagine this, you're in RT working in the emerge one day, and you have a COPD patient coming in, and they're presenting with signs and symptoms of shortness of breath, altered level of consciousness, hypercapnia. And I know what you all may be thinking. Okay, a typical COPD exacerbation. So now you're mentally prepping that BiPAP, your RT buddy's getting bronchodilators ready, you're getting that oxygen set up, and you both look at each other and you're like, okay, we know what we're dealing with, we got this. But what if I tell you that this patient's presentation is actually due to a complete different cause, which is yet not evident to us? And so just by show of hands here, how many of you have actually seen a COPD patient presenting this way before? That's pretty much everyone. And how many of you have immediately thought about intracranial pressure? Okay. And so this is the gap that I like to define as the clinical iceberg. So like the tip of an iceberg, the tip of that iceberg basically represents a fraction of reality. And think of it like COPD. Because as RTs, we are very highly trained to manage and recognize something like COPD. But then there's a more complex and hidden portion. That's the part of that iceberg that's submerged into the water, something that's not visible to us. And that's where the real danger is. It's where the real issue is. And so if we don't question this hidden complex portion, we actually miss risking what's truly going on with our patient long before it's even visible to us at the bedside. And so in the start of this presentation, I mentioned that this is a topic that's really special to me. And there's a reason behind that. Well, this journey actually began when I learned about a friend's condition who was also my roommate in Fairmont College. She was diagnosed with idiopathic intracranial hypertension. For 2 years, she was suffering with shortness of breath, headaches, several cognitive changes. It took about 6 months for her to be fully diagnosed at just the age of 17. This actually pushed me to dig deeper. In literature, I find that similar patterns where neurological symptoms are often misattributed to COPD exacerbations when that underlying issue is actually a complete different neurological condition like IIH. As I begin clinical practice, this leaves me with one question that I continuously come back to every single day. But how can I make today meaningful for the patients that I see? And with my first official shifts in the ICU just last week, I'll be honest, this question has become really real in practice for me. As respiratory therapists, I want to highlight that we're highly trained to follow patterns and protocols. But there's often a third dimension that we may overlook, and that's the risk of anchoring yourself to what seems so familiar and expected with our patient that we sometimes overlook to question what's new or changing. And if our focus ends up staying too narrow or tunnel vision, basically, we actually may miss something that's completely really important. As we go through this case, I'm going to be highlighting some RT key checkpoints, moments where we can pause and ask ourselves valuable questions, with the hope today that when you go to see your patient the next time, this presentation will give you one more perspective to consider. Well, we have to start somewhere, so let's talk about the basics of both conditions. IIH is a condition, a neurological condition where you will see increased intracranial pressure without an identifiable cause. And as RTs, I want us to focus on the symptoms, because quite often the symptoms can be non-specific and overlap with symptoms you may see in COPD. However, there are a couple symptoms that make this unique. That's things like nuchal rigidity or neck stiffness, which are pretty unique to IIH. COPD, we know COPD is our bread and butter, and you all are experts and pros at knowing what it is. But I just want to highlight COPD in the context of neurological complications. We know when we have a typical COPD exacerbation, we get a rise in those CO2 levels, and oftentimes it's really easy to attribute everything that you see with those neurological symptoms to CO2 retention. But it's always important to remember that there could be a complete separate neurological process underneath. Now that we have just a basic understanding of what these conditions are, let's actually talk about the case. And I want you to imagine it unfolding in real time. So we have a 6-year-old female, and she's already been hospitalized twice for COPD. She also has rheumatoid arthritis, and on the day of her admission, she is presenting with worsening shortness of breath. Day 1 is fairly routine for her. She's ruled out for a pulmonary embolism. Her echo suggests that she has pulmonary hypertension, and she's also treated with bronchodilators and steroids, like a typical exacerbation. Day 2 is where things really begin to shift. She's developing confusion, her bicarb is highly elevated, and symptoms at this point are being attributed to hospital delirium. Clinicians are basically giving this a diagnosis of ECOPD. Day 2 night is where things really take a turn. Now she's rapidly deteriorating, she's intubated for respiratory failure and airway protection. Day 3 is the moment that I like to call the red flag moment, because despite ventilation, she's developing myoclonus and nuchal rigidity. And this isn't quite fitting what the clinicians have thought about so far. Her EEG shows that she doesn't have any seizures, her CT head scan is normal, and so the team is now asking themselves, what are we really missing here? And so they do a lumbar puncture on her where her elevated opening pressure is quite high, which drops post-spinal tap. And this is that turning point of the case. Bringing me into day 4, she is clinically improving now. She's extubated, weaned off to CPAP, but she's still presenting with an unusual symptom of persistent neck stiffness. This brings me to RT checkpoint 1. I really want us to pause here and think like respiratory therapists. This is the point where we want to ask ourselves key clinical questions of day 1 and 2 of this presentation. That should we be monitoring something like neurological status for this patient? Should we think about ICP? Are all the neurological symptoms here being explained by CO2 alone? Or is our management protocol really going to have any negative effect or consequence on the brain? Because we are now trying to really think about that complex portion of that iceberg that I talked about when I started this presentation. Hypercapnic encephalopathy, and I know that I've already talked about this in the context of COPD, but it's just it's such a key concept that I believe it's worth revisiting, as it's central to how this case actually unfolds. And so, all I want us to understand as RTs here is that the key symptoms for this condition can easily overlap with other neurological conditions. And that can help us understand the challenge of our case. What truly delayed the diagnosis in this patient? Let's think about this in simple terms, like a diagnostic puzzle. We can actually integrate the different clinical clues that we already know. We can connect the pieces of information that we already know to uncover that complete clinical picture. You have one piece, hypercapnic encephalopathy, where you're seeing something like severe hypercapnia, but ventilation is clearly bringing improvement. And then you have IIH, a complete different condition that's presenting with unusual symptoms like neck stiffness or high opening pressure. And despite ventilation, it's evident to us that these symptoms are not getting better. Then you have an overlapping piece, altered consciousness and confusion, which is adding complexity to this case, and it's challenging a very straightforward interpretation. And this is the point where I want to say that good clinicians are those that learn to pause and question what doesn't quite fit with our patient right now. So let's actually understand this. It's actually, if you step back, it's 2 conditions, not 1. One being driven by CO2 retention, another being driven by elevated intracranial pressure. And the net result is that it's giving you the same neurological presentation. So essentially different mechanisms that are leading to the same effect. We can always take it one step further and break it down onto a physiological level. And you all know this diagram. I just want to point out one key thing here. The final main one common pathway, intracranial venous hypertension. So whether it's her CO2 retention or her pulmonary hypertension, the main thing to understand is that how all these different mechanisms actually lead to a rise in your intracranial pressure. Because it's not just about COPD or CO2 alone, it's actually understanding all these different mechanisms can help you understand how IIH can emerge in the context of the COPD. This research was further supported by an amazing principle, Monroe Kelly, which is basically stating that your skull is a fixed container and you have all these different components. If there's a rise in one of those components, all those other components must decrease, or else you will see a rise in your intracranial pressure. Day 6, we're finally at discharge of our patient. Our patient is discharged home with a full diagnosis of idiopathic intracranial hypertension, along with her diagnosis of COPD. RT checkpoint 2. These are the key clinical questions we can ask ourselves as RT on day 2 and 4 of this patient. Up till this point, we know that if ABG abnormality is improved with ventilation, but neurological findings persist, we should be thinking about what other diagnoses do we want to be considering. How can respiratory therapists contribute to identifying when neurological deterioration is solely respiratory in origin? When you're managing something like severe hypercapnia in COPD patients, are you really thinking about those other comorbidities? Because it's not just about managing ventilation, but it's actually about thinking about the protection that that ventilation needs to provide. And only then we can actually start thinking about management for these patients. Management can be divided into 3 sections to make things simple: ventilator strategies, diagnostics, and application. I do want to take a moment here to appreciate that this is a case that highlights the importance of not just following protocols blindly, but actively considering the broader impact of our interventions. It's made me reflect on my role as an RT, because I'm not just someone who manages a ventilator and looks at numbers, but I actually look at the patient as a whole, anticipate complications, and really help to guide a multidisciplinary plan. So what vent strategies do I want to talk about today? One for PEEP, and you all know what PEEP is. We know all the fun stuff that helps with alveolar recruitment and oxygenation, but today I want to talk about PEEP in the context of neurological implications. Well, one, PEEP can affect your intrathoracic pressure. It can lead to CO2 retention. It can decrease cardiac output. All these different mechanisms lead to one final result, an increase in your ICP. Just like that, we have permissive hypercapnia, an often well-known strategy used for our COPD patients where we're allowing higher levels of CO2 levels. And oftentimes, once again, this comes at a neurological cost because we allow higher CO2 levels, causing cerebral vasodilation. Net result is a rise in your intracranial pressure. And so once these ventilator strategies begin influencing something like cerebral physiology, diagnostics become essential to guide safe and individualized care. So what diagnostics do I want to talk about today? Well, for one, POCUS. When I need a rapid answer about my PEEP adjustments and diaphragm changes to see my effect on my CO2 levels, I can look at POCUS because it gives me real-time physiological insight beyond vent numbers. And I talk about POCUS, and I think it's a really special one because I know CSRT has had a course here where they've trained 117 RTs over the 3 years. Additionally, a lot of RTs also say that they have access to POCUS, which makes it a powerful diagnostic if advocated for more, especially with complex cases like this. EIT, electrical impedance tomography, when the question shifts to ventilation distribution and safer CO2 controls, we can actually use this tool to allow for real-time visualization of lung ventilation. As RTs, we can see overdistension, collapsed lung regions, and while not many RTs may have access for this, but once again, with advocation, we can work towards that, and especially for these type of complex cases. Near-infrared spectroscopy. I find this one really cool because now you have an additional layer of information. This is telling you about cerebral oxygenation, and sometimes telling you those changes before your SpO2 or ABGs, making it a great influence for cerebral perfusion and to see how your ventilator strategies are affecting that. Finally, brain tissue oxygen tension. And when that question is no longer about ventilation at the lungs, but oxygenation directly at the level of the brain tissue, we can use a tool like this. And you may be wondering, why do I need to worry about brain tissue oxygen tension? Well, your ventilator strategies have a direct influence on this. You want to ensure optimizing oxygenation and having stable CO2 controlling levels. RT checkpoint 1, and I do want to thank you all for remaining with me throughout these checkpoints, but I just want to pull one final one. I want to pull everything together for one final checkpoint. And at this point, we want to ask ourselves, like, are our interventions protecting both the lungs and brains? Because looking at these ventilator strategies and looking at these diagnostics, it's evident that ventilator changes can have a ripple effect. And that means we need to be intentional. So at this point, I want to ask myself that how can I adjust these ventilator strategies when I see patients with suspected neurological involvement? What hidden complications should I consider? How can I improve my assessment earlier to detect something like this? And I understand to answer these questions, we may benefit from a structured approach. And that's where I want to walk you all through an original framework for brain and lung protection. This framework consists of 4 key components: think, monitor, test, and advocate. I like to call this the RT roadmap. And most of us and all of us are here at the start, at the head of the bed, with tools that we know the best. That's our daily assessments, our smart ventilation strategies. As we move further along this RT roadmap, we have emerging tools like POCUS, which I talked about. And a lot of us are also here. And then we have advanced and specialized technology like EIT, near-infrared spectroscopy, and all those different cerebral oxygenation diagnostic tools, and some of us are here. And I want to highlight that this roadmap is not only about using the best and new technology out there. It's actually designed in a way that each step is meant to build on your confidence and judgment and personalized care depending on your patient. Think, which is the first component, means think beyond the lungs. And that involves daily assessments. And you may be wondering, why do we have to start here? Well, these are within our scope of practice. They're immediately actionable to us, and they're fundamental to safe patient care. They teach us to detect trends, notice any mismatches, ask ourselves the right questions. And they ensure that if we were to advocate for more advanced technology, we're doing so with confidence and context. It also includes a smart selection strategy, which means that I'm thinking about neuroprotection, not just lung protection, which means controlling my CO2 levels, optimizing oxygenation, preventing things like auto-P. The strategy should be individualized based on underlying pathology, but just remembering that you can always advocate for something like real-time CO2 and ICP responses. Monitor is the second component, monitoring cerebral impact in real time. When I talk about monitoring, I'm talking about ICP, and I know that many of us RTs may be thinking, where do I fit in with ICP monitoring? Because we're not the ones inserting external ventricular drains or directly measuring something like ICP. But here's the reality. Even if you aren't directly measuring something, you're likely still influencing it. And so it becomes essential for you to think about those things. There's 2 critical roles we can play here. 1, advocacy. If I notice that a respiratory picture is not aligning with a neurological picture, I can actually speak up for my patient. 2, I want to introduce the concept of volumetric capnography. This is a tool that you all know about, and it helps us to look at CO2 elimination over an entire breath, giving us a CO2 volume curve. This can tell me about my ventilation efficiency. It can also tell me about dead space in real time, and so it can play a real good role in ICP monitoring because it can allow me to really take control of those CO2 levels. Cerebral perfusion pressure is another component that I believe is very important. We know that your MAP and your ICP, the difference between them is your cerebral perfusion pressure, which is really important because this is basically what's determining how much of that oxygenated blood is getting to your brain tissue. RTs are really close to being able to monitor something like MAP trends because we do place arterial lines. And so we can minimize excessive pressures. We can once again think about those CO2 levels when we are looking at our MAP trends. Test is the third component. Test before you adjust. This means that moving away from large, reactive changes to a stepwise approach. Make those small, controlled ventilator changes in your PEEP and tidal volume. Monitor the real-time response, whether that's your SpO2, MAP, your ICP. The more data, the better. Assess the impact on oxygenation and cerebral physiology, and always see if you need to readjust if the outcome is not working well for your patient. Advocate for your patient. And I know that advocacy can have a different definition for every healthcare worker, but I believe that advocacy is not just about having a voice, it's actually a clinical intervention on its own. So what does it mean to be an advocate at the bedside? Well, for one, early recognition. RTs are often the first ones to see changes, and it becomes really important and a responsibility on you to speak up about it. Educate the team. If you know about the brain and lung physiology and the connection, then let others know. And sometimes that may involve you to advocate further for things like neuroassessments or eye exams for like IIH patients. 3, integrate additional measures, which means don't just look at one value, but actually look at your data as a whole when you're making a clinical decision. Prevent harm. Every ventilator change that you make, ask yourself, am I causing harm or am I helping the patient? I want to leave you all with a few key takeaways for today. Well, one, not all neurological decline in COPD is CO2 alone. If numbers look better, but your patient doesn't, that's the next red flag. The strategies that we can use to protect the lungs can unintentionally harm the brain. And with all of this together, you're not just ventilating the lungs, but you're influencing the brain, so let's actually practice recognizing that. One key message to remember from today is that when the brain and lung collide, still protected by us, even if not measured by us. And I say that because what we choose to notice today can truly change our patient's outcome tomorrow. And I just want to take a moment to go back to where I started this presentation about my friend's case and what inspired me. I want to emphasize again that IIH is a chronic condition, which means that our patients are affected both mentally, physically, and emotionally. And being respiratory therapists doesn't make us limited. It actually, our roles and our responsibility goes beyond just respiratory support. We're educators, we're advocates, and we're critical thinkers, and that means we have the power to make a positive and meaningful difference in a person's life. And yeah, I believe that power truly begins with every clinical decision that we make moving forward from today. Thank you.
Thank you, Noor. We have time for some questions.
Hi, my name is Dennis. I'm a respiratory therapist. I just want to ask, great presentation. How do you differentiate
you.